intestine. Now, I don't know if we talked about it yet, guys, but if you were to cut that stomach in half, there's some very important anatomy inside the stomach, that being the rugae or the rugae folds. Did we talk about that?
Yeah.
We did. What was the purpose of those rugae or rugae folds?
To help like digest the food.
To help
right?
churn the food, move it around, help digest it. And as Jay just said, that food then transforms to another substance that we call chyme. Chyme, that's actually what you vomit up whenever you vomit. It burns your throat, it's stomach acid, pretty gross. Yeah. So cardia, fundus, and body, three very important portions of the stomach, especially that fundus and body in relation to where the barium is going to sit as we're moving that patient around from supine to prone to lateral, so on and so forth. So before I even get to it, just based on what you've observed, in what position do you think the patient would be in would the barium be in the fundus? What position do you think the patient would be in? So think about, or if you've seen it in clinic and paid that close attention. What'd you say?
Would they be supine?
Not
No,
LAO.
no. Maybe upright.
Supine?
Where you said the barium?
I heard one correct answer there. That's going to be supine. Supine, the barium's going to fall towards the fundus. And I'll show y'all why in a second.
Oh.
So, if the barium's in the fundus while we're supine, what position will we be with the barium in the body?
Upright.
Be the reverse. We're going to be in the prone position.
Oh, prone.
Now remember, one way you can remember these obliques as well, if we're supine, it's also going to apply to what two obliques? LPO
and RPO.
If we're prone, that'll also apply to what obliques?
REO.
LAO and REO. So that same concept's going to apply about the barium being in those locations. And I have a great little chart to show you as we move on here. It's really good to take a picture of. I'll tell you when to. So moving on, guys, a few more portions we're going to talk about. The very last portion before that stomach terminates and it becomes the small intestine, specifically the duodenum, is that pyloric portion. That's going to consist of the antrum and a narrowed pyloric canal. That's this region right here, guys. And be careful because there's a little bit of overlap. When you start to see that portion curve, making that C shape, that's when it becomes duodenum. This is not stomach right here. The stomach ends right here at that pyloric sphincter, which narrows, and then becomes the duodenum. Now, do you guys remember from fluoro, doctors calling that the C loop? Have y'all heard them use that term? That's what they're talking about when they say the C loop. They're talking about the pylorus and the duodenum. It actually makes a C-type shape. That's that C loop. Our last piece of anatomy here, guys, the lesser and greater curvature. Please remember the lesser curvature serves as the right border of the stomach, while that greater curvature serves as the left border of the stomach. And that's based on anatomic position, once again, not looking at the diagram. We're talking about anatomic position. And then finally, that cardiac notch, that's going to be in that cardia area. That's the actual notch that we see right here, guys. Here, that's the sphincter, that's the notch. That's that sharp angle at the esophagogastric junction that we can see very well on our x-rays, by the way. So know how to label that. I've got some example x-rays coming up here shortly. So of course, those doctors are always looking for that C loop when they're moving that patient around. And they'll often move those patients around in multiple positions because if you haven't noticed, not everyone's anatomy is shaped the same. It's based on those body habituses that we always talk about. You're going to have to move that patient in a different type of oblique to be able to demonstrate that C loop profile properly as it's starting to move, it's starting to move towards the small intestine. And y'all be thankful, guys, because boy, y'all have it made in the shade now with upper GIs. I'm sure y'all have noticed whenever you're doing upper GI, the doctor's taking little snapshots, little films, they're saving images. It used to not be that way. Even when I was in x-ray school, we had to do plain films of upper GIs. So the doctor would do the whole fluoro, he would take his images, but then he would say, I want the plain films, and we'd have to take a sequence of plain film x-rays with the upper GI. And y'all used to have to actually comp on those too. Now, you pretty much just comp on the fluoroscopy part of assisting the doctor, setting up the room, dismissing the patient. It used to be a lot more complicated than that. Thank God for technology, right? In fact, I remember when I moved to Houston, I was working at a little government hospital in Louisiana as my first job. And while I was there, that was back in 2008. Yeah, that seems like a long time ago now. 2008, they were still doing the plain films for upper GIs and barium enemas. And I remember I moved to Houston in 2009, and that's when I started working at Texas Children's, and they were just doing the films that the doctor takes. They weren't doing the plain films anymore. I was like, y'all don't do the plain films? They're like, no, the doctor takes his images. I'm like, are y'all serious? They were serious. Yeah, it was so much faster not having to do those plain films anymore. So it has trended towards that direction. I know there's still a few old school doctors that really like those plain films still, but we're seeing that less and less. Okay, guys, so some entrance and exit points. Of course, they're called sphincters. That's those little narrowed areas where the muscles contract to move the contents in or out of the stomach. We have the cardiac orifice. That's going to be your opening between the esophagus and the stomach. That cardiac sphincter specifically controls that opening. It allows those contents to pass from the esophagus into the stomach. Then we have the pyloric orifice, which is that canal near the duodenum, controlled by that pyloric sphincter. And that's going to move the contents from the stomach to the small intestine, specifically through the duodenum. So of course, if you're doing a small bowel, combined with the upper GI, you're going to keep following those contents all the way as it gets towards that last portion of the small intestine, that being called the ileocecal valve. Don't remember that? That's going to be when the contents enters the large intestine. While y'all writing, just back on those plain films for upper GIs, boy, let me tell you, I'm sure Miss Smith, she probably did some of those as well. It's hard to get those x-rays. The stomach is one of the most squirrely organs. I call it squirrely because it just wants to move all over the place. It is hard to get that stomach centered correctly on a film. You can be like the best tech in the world. You think you got that film right where the stomach is, you take the x-ray and it's way off. That stomach moves all over the place. And what really was bad about that, I remember doing my upper GI competency as a student. I think I had to attempt it 3 or 4 times as a student because, at least in my school, you had to get all the films perfect to pass it. And if one was missing, like one had a piece of that stomach cut off, you failed it. And oh my God, it was a nightmare. It was a nightmare getting that competency done. I was so stressed out during those. You recall that too? Yeah. I'm telling you guys, you haven't made the shade with these fluoros now. Be thankful. It's so nice. Am I being filmed?
Yeah.
Okay, I was just making sure. It's okay. Yes.
I don't know
I
why.
get nervous on camera. I don't know why. But yeah.
Samantha films every single class.
I know.
I guess I'm more used to her doing it. It's on a tripod. You like to really focus there with your phone. It's okay. Yes. Question?
So I don't know why I'm getting confused right now, but like say, what side is the lesser and the greater? Like
Lesser's right here. Greater is right here.
So
That's the left side. That's the right side.
So think of it as medial lateral.
Because we're talking about anatomic position as if the patient's facing you right now.
Yeah. Okay.
So left side, right side. This is the lesser. This is the greater.
Okay. So that's how it sits
So
in there.
right
It's like
lesser.
that
This would be like your average sthenic patient.
Okay.
Because remember with your body habituses, like
Right
for
lesser,
a
left
asthenic
greater.
patient, it's going to be hanging really low like a J shape. Your hypersthenic is going to be very horizontal in shape. So this would be just your average person. Majority of your population right there.
Right lesser, left greater.
And if you have someone with a lap band, of course, they're chopping that stomach all up. Have you ever seen one of those before? Those lap bands where they remove a portion of the stomach or they compress it down so you can hold less contents in your stomach.
Is that like the gastric bypass?
The gastric bypass is the removal of the lap bands where they actually just use a band to shrink it down. All right, just another frontal view there, guys. Same anatomy we just talked about. Some stuff missing, of course, but this is a great example of how we can quiz ourselves of what we know. Guys, if I point to that right there, what would you tell me that is?
That is
The cardiac
Cardiac notch.
notch.
There's a sphincter that's located here. It's called what?
The cardiac
Cardiac sphincter.
sphincter.
What portion of the stomach is this?
Fundus.
Fundus. This would be the,
Body.
this would be what portion? Pylorus. Pylorus. What is this edge called?
The greater curvature,
And what is this
lesser
edge called?
curvature.
Very good. Very good. It's so shiny and pink, right?
I look so perfect if you spoke them.
Stomachs don't actually look like that, by the way. I mean, color-wise. You ever seen a stomach?
Yes.
It's kind of just pale looking, kind of gross.
I seen the inside of it.
You see the inside here? They're not pretty and pink. They kind of just like Pepto-Bismol, right? Reminds me of Pepto-Bismol.
When they put the thing down your throat, I got the.
Oh, the endoscopy. Yeah, I've had that done
pictures of
too.
the inside of my stomach, it's ugly, it looks like rings.
It is very pink inside your stomach, just a darkish red.
Yeah.
I showed y'all mine though, didn't I? Didn't I show y'all my? I haven't showed y'all my endoscopy and colonoscopy. I got pictures of mine too.
I got pictures of mine.
If y'all want to see inside my intestines, I got pictures of it. Maybe y'all don't want to see that, but I had to have that done for, I had a bunch of polyps removed, so. Yeah, I'll try to find it and bring it if y'all want to see. It's not gross, it just looks like inside of intestines and stomach. There's a great picture there, guys. I would take a picture of that that's not in your book. This is a really great diagram I found, guys. It kind of just labels everything we just talked about. Really great reference picture right there. That's everything we've talked about so far. By the way, alternative names.
Yeah, I was looking
I
at
don't
that.
think they'll use these. These are like Latin names, but cardiac notch can also go by Incissura cardiaca. And angular notch can go as Incissura angularis. You sound fancy when you say it like that, right? It should sound more educated. The Incissura cardiaca.
Say that to the doctor.
He'll look at you like you're crazy because they don't remember half this stuff. These landmarks. Like, oh, that top part of the stomach. You're like, you mean the fundus? Yeah, that. I want to see that. Tell you, you know more than the stomach. You know more than the stomach. You know more than the doctors do sometimes. All right. Also, this area, which is the body, can also be called the gastric canal. It's a good thing to write down. Remember, one of those alternative names. The body, inside the body specifically, can also be called the gastric canal. The rugae can also be called the mucosal folds. Mucosal folds.
Do we have to know when it goes into?
It's an alternative name, yes.
And the whole digestive tract is the alimentary canal.
Very
right?
good, yes it is. The whole digestive tract is called the alimentary canal. By the way, Sindhu, it's good to see you back. I almost didn't see you sitting back there. Welcome back. All right, and there it is on X-ray. Very pretty X-ray. They're not always this pretty, by the way. In fact, they're often quite ugly. But here's all the landmarks we just talked about with a few missing. Of course, there's the esophagus. There's that cardiac notch we just talked about. And we see air in the fundus. The air is indicated by that black portion, of which there's just a tiny bit of air at the top. Now, based on what I just told you, that means we can know without a doubt this patient's in what position?
Supine.
Supine, because the air is in the fundus. And I got another diagram coming up that's going to explain that a little bit better. We have barium found throughout the body, also in the pylorus, also in the duodenum. Here's that lesser curvature. Here's that greater curvature. Pyloric antrum of the canal is this narrowed area. Pyloric sphincter, very distinct in that it narrows down right before the stomach terminates and becomes the duodenum. This is an important landmark right here, that being the first portion of the duodenum. Kind of pokes up like an actual bulb. That's why it's called the duodenal bulb. We look for that too a lot on our upper GIs. As you can see, the duodenum curves in that beautiful C shape, C loop, and you'll see something called the descending duodenum. Now, I'm sorry to say we've got portions of the duodenum that we have to learn about next. Much like the large intestine had different portions, there's portions of the duodenum that we have to learn to label. That's the descending. We've got a few more we're going to talk about in the coming slides. So stay tuned on that. Now, what were the three main portions of the small intestine called, guys? Duodenum,
Jejunum,
Jejunum,
ileum.
ileum. Which one's the shortest and the widest? Duodenum, which one is the longest?
Ilium.
Ilium, very good. Question?
Yes, sir. So how is this different from a patient if he was supine? Because
They are
because
supine.
Or not supine, meaning upright. Because if the
Good. That's a really good question. So how's this different from a patient that's upright? There's a really clear indication if they're upright, guys. Think about gravity once again, because air rises, fluid falls. If they were upright, we would still see air in the fundus, but how is the liquid going to look? It's going to have a straight line going across because of the gravitational pull of the liquid.
You'll
I
see
got
the
some pictures of that
separation.
too.
thank you, sir.
You're welcome. All right, so let's talk about body habitus. Then we're going to talk about how that barium looks inside the stomach based on position. Of course, stomach position, guys, is going to be greatly affected by that body habitus. Higher and more horizontal for our hypersthenic or very wide obese patients. Lower and midline in the asthenic patients. For our sthenic and hyposthenic patients, more so that average shape we're used to. But do look, there's quite a difference just from sthenic to hyposthenic. Here's what all the diagrams are based on. 50% of the population. Hyposthenic being the next biggest portion. It's going to start having that elongated J shape. You go to asthenic, look how low that stomach goes, guys. And have y'all seen fluoros on an asthenic patient yet? If you get a very skinny person, try to get in there and watch that, because I'm telling you, that looks like an exaggeration, but it's not. The stomach will be like down in the pelvis sometimes. It hangs that low. It doesn't hurt the patient, it's normal. It's just the way their body is shaped. Hypersthenic being the rarest, that's going to be our very large patients. That's going to be that more horizontal, widened shape. Also, what else do you notice is changing location in that picture? See that little green dot?
Gallbladder.
That's the gallbladder. There's the average location between these two. Look how low it gets on the asthenic patients, quite low. And then the hypersthenic is a little bit higher. Okay, what's our main functions of the stomach, guys? 4 great bullet points there, guys. I want y'all to remember. Of course, storage area for food during the part of digestion. It's going to secrete those acids, those enzymes, or chemicals that chemically break down the food. That's a chemical process that your food is being broken down. It mechanically breaks it down by churning combined with peristalsis. And then that's going to become that substance we just talked about, chyme. That's chemically and mechanically altered food that leaves the stomach. So it enters as food, it leaves as chyme. Enters as food, leaves as chyme. Such a gross word too, chyme. Just sounds nasty.
If you think about chime, then
Like a chime? Well, it's not making any ringing noises like a chime, unfortunately. It looks like the word chime though. Hmm? Almost. You tired of talking about the
No, I
stomach?
have like a knot in my throat. I'm like feeling sick.
You don't like talking about the stomach? It's gross. We're not even to the intestines yet. Maybe that gets a
The
little
whole
grosser.
digestive system is just bursting. I would not.
Oh, just some things you don't want to think about. Of course, if you got a stomach like me, you introduce a milk product in there, you're gonna have a heck of a good time. I say that sarcastically.
Yeah.
As a lactose intolerant person, it's like introducing poison in my stomach.
We know.
And it's so terrible. Because I love ice cream. I love ice cream, but I can't ever eat it. It's just not fair. You always want the things you can't have, right? Especially, and we have Bluebell ice cream around here, man. That's not cool, man. I mean, come on. Why, Bluebell has no lactose-free options. I've been writing these letters. I've been writing these letters to Bluebell to get me a lactose-free option, but they never respond.
Ludwins.
Hmm?
Ludwins. I hope I'm saying it right.
Ludwins?
Ludwins or Lud, yeah, starts with L.
I mean, I got me a mod pizza for lunch, and they got lactose-free cheese.
Yes.
That ain't
That was a
cheese,
great
then.
lunch. Hey, it tasted like cheese. I don't care what it was, but it
You
tasted
know,
like cheese.
HEB has that like sherbet ice cream. It's just.
That's sherbet. It's not.
It's
ice
good
cream.
though.
So what about frozen yogurt?
Yeah.
I want some Bluebell.
Well, no, I guess.
I want some Millennium Crunch Bluebell. Lactose free. Yeah.
Just eat it on the toilet.
Gelato is. Gelato is really good.
Living life on the edge.
I do
Take the nasty ones.
take the lactate pills, but they don't always work.
And I'll be on the edge. I'm lactose intolerant, but I still have my ice.
Right, I'm mad.
All right, guys, air barium distribution. I want y'all to take a picture of this diagram. It's a really great reference diagram. The black referencing air, the white referencing barium. Just like I told you guys, when we're supine, wait a minute, did I write that backwards? No, I didn't. No, I didn't. When we're supine, the barium falls back towards the fundus. So this is how I kind of describe it. This is what helps me. I think about if I'm standing up, here's my stomach. As I lay back, I'm falling backwards, right? Falling back. So as I fall back, the liquid also falls back
Okay.
and goes towards the fundus. Does that make sense?
So then the stomach isn't like
No, it
vertical
doesn't.
like that. It's kind of.
It curves in a stent patient. It's gonna be more vertical for your skinny
No, I don't
patients.
mean like
though.
shape wise. I mean like.
So how come here it's showing it's on the bottom?
Like if this image were
Because it fit.
pulled, it would be kind of like
I
this.
thought it goes
along.
to the fundus.
So like you have the fundus is more internal.
A little bit,
Then-
yes.
okay,
A little
so
bit,
that's
yes.
why it
I see what you're
Supine?
saying. So let me describe that again, guys. If I'm in a supine position, or I'm starting upright, I'm standing up, I fall backwards. I'm falling back onto my back. I'm going supine. The liquid or barium also falls back with me. So the barium will be
Shows down.
at the fundus, while the air will be in the body. That's what we see right
Oh,
here.
barium.
Do you have a question, Cody?
So, like according to the middle
Barium
one,
goes to the fundus.
like big
Okay.
prone there,
I was looking at the air.
wasn't that past image?
It was. I may have misspoke.
Yeah.
Huh?
Yeah, I might have misspoke on that. I apologize.
The-
On that X-ray image,
Yeah.
that was a prone image. Did I say AP?
Yeah, you said
Supine.
That
That's
was
what I'm
prone,
confused
sorry.
about.
I misspoke. So, speaking of prone, here's the concept on prone. If I'm standing up and I go forward on my belly, I'm falling forward. The barium also falls forward towards the body, like we see right there.
Oh, forward.
That, for me, is the easiest way to remember those two. So, supine, I fall back towards the fundus. Prone, I fall forward towards the body. Does that make sense? Erect is going to share a similar distribution as the prone. Because everything's going to fall down with gravity, barium is going to rest in the body, air is going to rise towards the fundus. Now, we have some overlap, of course. Supine, obliques. If I am LPO, it's still going to look like the supine. If I'm RPO, it's still going to look like the supine because I'm still technically in a supine position. I'm just obliquing. For the prone positions, if I'm REO, it's still going to look the same way. If I'm LEO, it's still going to look the same way. Does that make sense? So you'll see the oblique stone there. Don't let that throw you off. Determine whether it's a supine or a prone, and you can still figure out what we're looking at. Yes?
So if they're doing those positions, they're not doing it mostly to move the barium, they're doing it to just see a different view of the stomach then?
Right, exactly. The barium distribution is not really going to change from a prone to an REO, but the stomach's going to be thrown to a different side of the body. You're going to see it in a different shape. But the barium distribution will remain the same. Good question. Now there's one more I don't see up here. That's the decubes. What do you think is going to happen on decubes, guys?
The air is gonna go up.
We're going to see that straight line because of gravity, but it's all going to fall to one side of the stomach. If I'm in a left lateral decube, it's going to fall towards the greater curvature. If I'm in a right lateral decube, it's going to fall towards the lesser curvature. Does that make sense? Y'all on board still?
Say that again, right?
So if I'm in a left lateral decube, the barium's going to fall towards the greater curvature. If I'm in a right lateral decube, the barium's going to fall towards the lesser curvature. We're still going to see that straight horizontal line indicating there's gravity present. All right. And guys, actually, before I forget, in that guide I sent you guys last semester, you know that PowerPoint with all the positions?
Mm-hmm.
In the fluoro section with upper GI, there's a lot of demo X-ray images in there showing that barium distribution of what I just talked about. Really great reference point for this slide right here. Or go back and look at that. Excuse me. Okay, guys, so if I look at this image on the left, based on what I just told you, what position is patient A in?
That's good. So air on the top and.
This one right here. Barium's in the body, air's in the fundus. So if I
Prone?
fall forward, barium falls in the body, so what would it be?
Prone.
This would be prone. This would be supine because the barium's falling back towards the fundus. Making sense? Now we know for sure this is a flat supine because if you look to the vertebrae, do we see Scotty dogs? Yes or no? We don't. If we saw Scotty dogs, we'd know it was one of the obliques. There we go. AP supine, barium in the fundus. REO prone, air in the fundus. Now, as far as like knowing that's an REO, they don't expect you to know that because you can't see enough of the spine to really determine that. They'll often already have that pre-labeled for you as an REO. And they would ask you a question like, for an REO, for this REO stomach, where's the barium located, blah, blah, blah. Or they'll have in a text question, if a patient's in an LEO position, where would the barium fall? They'll ask it that way. They're not really going to focus on having you label the oblique specifically. They'll ask you questions about it. But they will expect you to know whether it's supine versus prone or lateral.
The last thing is just always buried in the body. These is buried in the fundus.
Wait, say it again?
The last thing just go back.
They're just flipped.
Okay.
They're the same images. They're just reversed.
I have a question.
Yeah.
Why doesn't it, when you're laying prone, why doesn't it like coat the whole?
Because there's always going to be air in there. It's the way the air basically is
What-
rising.
Air fall in the middle. Like if I had a full bottle of water.
It's
what
still
would-
gonna. It's never gonna rest just in the middle. No. I know what you're saying, but it's always gonna either rise up or go down.
Is it because different parts of the stomach are like have like different, like I guess, depth to it?
Could be.
Cause like,
I haven't really thought about that deeply before, but
Cause it just doesn't
might
make
be.
sense.
Good questions. Good questions.
Can you say that?
Hmm?
If they fall back, it does what? If they go forward, it goes what?
You want me to say it one more time?
Yeah.
All right. So if I'm standing up, I'm having the patient lay back on their back for a supine. I'm falling back. Remember, I have liquid in there. I drink barium, so the barium's going to fall back with me toward the fundus. Now, if I'm standing straight up and I fall forward, going prone, the barium's going to fall forward with me and be in the body of the stomach. Now, one thing to always remember, guys, where the barium is, the opposite area is where the air is. So if I have barium in the body, I have air in the fundus. If I have barium in the fundus, I have air in the body. They're always inverse to each other. Okay?
What do you say, where the barium is, what?
Where the barium is, the air is in the opposite location. So if barium's in the body, there's air in the fundus. If barium's in the fundus, there's air in the body. And that's the two main areas we look to, guys. Barium from the fundus to the body. That's the two main locations that we're analyzing. Fundus versus body.
Not the
So we're not going to be
pyloric.
like, oh, it's specifically in the pylorus or specifically in the cardiac antrum. We're always going to indicate it by fundus and body on barium. Okay, so let's start talking about the small intestine. Now, when we talk about the small intestine, we're talking about the region that goes from the pyloric sphincter to the ileocecal valve. Average length of the entire small intestine is about 22 feet. If you were to stretch that all out, it's about 22 feet. There are mucosa found interiorly within the small intestine, these little finger-like projections that we call villi. That's what's going to further that digestive process through the absorption method. It's absorbing all those last minerals and things our body needs before it gets to the large intestine and we start eliminating the waste. Of course, what we just talked about, guys, duodenum, jejunum, ileum being the three main portions. And here's what I was talking about earlier, guys. We have 4 main regions of the duodenum, even though it's the smallest, that we have to label. Now, good news, we don't label portions of jejunum and ileum. We only label specific portions of the duodenum, that being that C-loop portion specifically. So, we have the first portion, it's called the superior region. As it goes down, that's the descending region, kind of like the descending colon. Y'all remember that? Then it goes across, that's the horizontal region, kind of like the transverse colon, very similar.
Mm-hmm.
Then it goes back up to the ascending region. At that point, we get to what's called the duodenojejunal flexure, and the rest of the intestine becomes jejunum, and then eventually ileum. So I'll go through that again, because that's a lot. Once we leave the pyloric sphincter and enter the small intestine, duodenum specifically, we have 4 regions that we're going to travel through. First being the superior region. That's where that duodenal bulb is. We go down the descending region, right here, across the horizontal, slightly back up again to the ascending, that's the 4th, and it ends at the duodenojejunal flexure. And that's whenever it becomes the jejunum. So there's 4 portions of that duodenum that we have to be aware of. 4 main regions. Superior, descending, horizontal, ascending. 1st, 2nd, 3rd, 4th.
Is the pancreas always strongly located around that area?
Yes, it is. There's actually a funny term for that I'm about to get to on the next slide if I'm not mistaken. It's nestled in there, all cute and cuddly.
What was the last portion of it?
Huh? The last portion is the ascending region, and then we have that duodenojejunal flexure.
Okay.
That's whenever it becomes jejunum. Now, you don't need to know this little muscle, but just in case you're wondering how it all stays in place, there's a specific muscle called the ligament of Treitz. That's what holds that C-loop in place, so it doesn't all fall out of your body. Ligament of Treitz. Yes?
If that rips, it's all fine.
I have to do something to secure that in there because everything will start falling down.
So is villi?
Mhm.
Just what is that? Villi or villi?
Villi.
Is that another name for mucosa or?
So yes, that's the little fingers that absorb nutrients of that chyme as it's going through the small intestine. Because that digestion still continues all the way through that small intestine. Villi. All right. So, I wonder if I have that slide. I do. I'm coming back to that. Okay. I like to talk about that pancreas thing we were just talking about. I'm coming back to that though. Okay. Duodenum. We're going to talk a little bit more about that, guys. That's going to be about 8 to 10 inches long. It is C-shaped. That's why they always call it the C-loop. It's the widest portion and shortest portion. I keep saying that because, man, they love to ask that question on the registry, guys. Widest and shortest portion, that being the duodenum specifically. It's fixed in position and located specifically in the retroperitoneal space. And there's that 4 portions that we just named, guys. We have the first portion being the duodenal bulb. We have the portion that joins the jejunum. That's where that duodenojejunal flexure. And it's supported by that muscle called the ligament of Treitz. You don't really have to know that last part. That's just if you want to know. Duodenojejunal flexure. Once again, that's where the duodenum ends or terminates, and the jejunum begins. Mr. Norsworth, we're going to have him make a cameo in the next chapter when we talk about urinary system. He loves talking about urinary system.
He sensed disturbances in the course.
It's too though. That's my baby too.
We're weird. We love what we talk about around here. What you talking about? It's not weird. I'm trying to take a nap. Yeah, I love learning this stuff when I was a kid. I would get the anatomy books out and follow all the intestines and man, I love going through books like this when I was a kid. That was my childhood. Yeah. Mutant Ninja Turtles, of course.
Where specific flexures are in the small intestine, like
Yes, so if we go back, these 4 portions, I do need to know those. So the superior, descending, horizontal, and ascending regions of the duodenum. That's just the duodenum, not the entire small intestine.
You said 4 parts of what?
4 portions of that duodenum, or that C-loop. You do need to know those 4 regions. Absolutely. It all makes up that C-loop. Yes. And y'all see how cute that pancreas is all nestled in that C-loop? It actually has a name to it. We're going to talk about in the next slide. I always love to talk about it. It's a great little romantic line you could use on your spouse or significant other.
Hey, nothing romantic about small.
You could say, honey, I just want you to know you're as cute as that pancreas nestled in that C-loop. And we call that the romance of the abdomen. True story. It's called the romance of the abdomen. Is that the most romantic line you ever heard? Like, honey, you remind me of the head. You're as beautiful as the head of the pancreas nestled in between that duodenal sea loop.
No.
Mm.
I would punch him.
Use that on your spouse or your significant other. I'm telling you, that pickup line works like a charm. That's how I met my wife, you know. When I proposed, I said, you remind me of my pancreas nestled in my sea loop.
That sounds like,
well,
what's that? Where is that at? Oh.
Oh my goodness.
like, wait. You heard that?
Huh?
Just call me a turd.
Yeah.
My turd. I didn't call her the chyme inside there. I didn't call her a turd. I called her the organs, you know.
No, I was trying to.
That's why it's called the romance of the abdomen. It's just nestled in there, all sweet and cute, snuggled up.
You just tickled, huh?
So,
I think it's funny. I'm very tickled. All right, what time is it? How long have I been going here? Y'all need a break?
Oh my god, yes.
Yeah, I'm tired of this time.
Have I been going
40
over an
minutes.
hour?
Hour and 5
Yeah,
minutes.
10-minute break, guys. Go ahead and take a 10-minute break. We've got about 45 minutes of class left after you get back. Be back at 2:15, guys.